It's just a huge honor for me today to be podcast interviewing one of my neighbors right here in Phoenix, Laura Corbin, RDH, AAS, BFA. That stands for Registered Dental Hygienist with an Associate of Applied Science and a Bachelor of Fine Arts. She is a registered dental hygienist with 14 years experience in a periodontal practice, providing non-surgical periodontal therapy and periodontal maintenance. Laura believes in using the latest technology to achieve the most predictable outcomes for her patients and has used a periodontal endoscope for the start of her career in dentistry. A master trainer of OraVu's DeVa dental endoscope, Laura also delivers educational presentations on the topics of visually scanning and root planing. Laura serves on the Arizona Dental Hygienists Association board as treasurer. And as a past president, she earned her hygiene degree from Phoenix College and has a BFA from Arizona State University. Thank you so much for coming on the show today. How are you doing?
I'm doing great. Thank you so much for having me, Howard. I really appreciate it.
Well, I really wanted to get you on here because, the whole show's aimed at, I think the only value of knowledge is if you can transfer it. Who cares what you know if you don't tell anyone else? And now that I'm 58, just had my sixth grandkid, I'm focusing on dentistry for my grandchildren when I'm gone. And so I'm trying to focus this on a quarter of our listeners are still in dental kindergarten. And it's neat to kind of impart these lessons. And the lesson I wanted to bring you on for is that when I was in dental school, it was all the things that you were talking about of doing everything to save the tooth. And then titanium implants came along and everybody thought, the best way to treat this tooth is just throw the thing away and put in titanium. And that was the miracle for 10 years. And then after 10 years, everybody's looking at these implants and saying, oh, they still got peri-implantitis. And this wasn't exactly the miracle thing we were looking at. So now, the last 10 years, I'm seeing a shift back to conservative stuff where people are realizing we need to just save the natural tooth. And just replacing everything with artificial $6 million man parts isn't necessarily the biggest. Have you seen that transition in your own practice?
Well, I think that it's kind of like you say, the pendulum swing. On the one hand, we swing all the way to one side and everybody's all about the implants. And then we kind of realize that, but people can still have problems with implants. You can still have failing implants. You can get peri-implantitis. And if you have a failing tooth next to an implant, that can affect the implant too. So the best option is really to figure out what's best for the patient. If the tooth really can't be saved, then an implant sooner rather than later is probably the best option. But then again, if you have a problem with that implant, you're going to have to be able to treat that peri-implantitis because you don't want to have to replace that implant and then, add additional investment on the patient's part, not to mention pain and suffering. So I think that we're swinging back a little bit more toward the middle. I doubt that we'll go completely toward old-time dentistry where periodontists used to try to do anything to save a tooth. And now, I still have some patients who come in and they have roots of 3 triple-rooted teeth hanging on by the skin of their little roots, but they're still there. And if the patient has excellent home care, it's actually sometimes still an option for them. So I guess what my answer is, the short answer is, yes, we are more conservative, but we still keeping our implants.
Yeah, and that's all true. So for these little kids in dental kindergarten school, where the rubber hits the road, and I got an MBA from ASU, and I've already lived 58 years, and you have to warranty it 5 years. I mean, if it only lasts 5 years, in my 58 years, I would have had to have it replaced 11 times. And when you come out of school, some of these young kids will see an incisor snapped at the gun line, and they're like, I can save this, and they do a root canal and a post buildup and this big old crown, and they charge out, thousands of dollars, and then, 1 year later, the patient comes back, and it's in their hand. Well, you did great, but I couldn't afford to do this 58 times for one tooth. So I draw the line at 5 years. We warranty everything we do for 5 years. So if some young kid is coming to my office and he was associate, he did that, I would take the root canal buildup and post crown and I would apply it to either an implant and a crown or a 3-unit bridge. And I know this sounds crazy, but I still think an anterior 3-unit bridge is more predictable, aesthetic, pleasing than an implant and a single crown, because I mean, when you replace a central incisor with a single root form implant and a crown and you nail it, I honor you. Just come by here. I'll nail down and kiss your feet. That's tough, but it's got to last 5 years, or it just doesn't make economic sense. I mean, these kids are in dental school. That was 4 years. Could you imagine getting this done? A root canal, billet, and crown. It didn't even make it to the end of dental school. I mean, so you have to diagnose aggressive enough to last 5 years. And that's, I think that's a really good checks and balance. And I used to get really upset and stop using some endodontists because they would do everything and then it ended up being pulled. And I said, well, it didn't work, man. Are you going to give the money back? No, man, I did everything I could. I tried my best. And it's like, well, your best wasn't good enough in diagnosing and treatment planning because it didn't work. And that's why I kind of was hoping that endodontists would start placing implants, because if I got an hour here and I can make the same money either way, then I know you're probably going to do what's right. If you if you can only make money doing treatment A and zero on treatment B, you got to be really busy and successful, and to always make the right decision if that's not internal. But I just think 5 years is a great cutoff. Do you have you seen a lot of people warranting their stuff 5 years here in town?
It seems to vary a lot. I think that there's usually a minimum of 3 years, because that's usually, if something's going to go wrong, 3 years is like the minimum, the maximum time. But then sometimes it takes up to 7 years for an implant to have problems, especially if it's related to the cement that they use. So I think that they're going back toward things like screw retained implants being more prevalent.
Screw what?
Screw retained versus
screw retained.
Cemented implant.
I thought you said screw train, and I'm like, screw train? I have not heard this. I'm thinking of a chain on an implant.
So one of the things that you bring up is like anterior teeth. People want to save their anterior teeth. Obviously, they want to save all their teeth. I've done a lot of cases using the dental endoscope, where we've been able to save like 9mm pockets on an anterior tooth and have that tooth be vital many years later. So this is where that more conservative approach of treating versus automatically extract and replace can come into play if the tooth is not due for a root canal necessarily. One of the things that I really love doing is trying to find out if there is some retained calculus, which we're able to use dental endoscope and see. We can remove that calculus and have a chance for healing, and it's a lot less of an investment on the patient's part than immediately pulling the tooth or even doing gum surgery is.
There's a difference between boys and girls. That's just obvious. And lecturing 50 countries around the world, when you get to poor countries, the men just don't care, and they'll lose all their teeth, and they don't seem to have a problem eating. And I saw this in my own family. I went to one of my grandma's funerals in dental school, and some of my uncles were like 80 years old and were edentulous and threw their dentures away years ago. And they would sit there and eat almonds. But like when you go to more poor countries, more developing countries, the men just let them go and usually fall out. But the women only do canine to canine. So you go to so many cities, and the women, they do their hair, and they got a little flower in there, and they got 6 PFMs, upper and lower, and 0 back teeth. So, and then in the United States, in a wealthy country like this, women get like 85% of all the plastic surgeries and things like that. And there is a difference in what they'll do to save a tooth. But I mean, unless you're the stud of all studs, avoid women's anterior teeth placing implants until you've got at least 100 under your belt. I mean, I can't even imagine how many Ralph's placed by now. How many do you think he's placed?
Oh gosh, I couldn't even begin to guess. He does a lot, and he does very successful ones. So I don't even know how many years he's been practicing. So
plus the implant's going to stay in there because they come out, they know he's a black belt, and he's just going to kick their butt. They're just scared to come out. We're talk about your journey of OraVu. Am I pronouncing it right? OraVu?
OraVu. It looks like OraVu. Yeah.
Nice. That is nice. I really like that. So OraVu, I've seen that before. I mean, you wouldn't go to your dentist if it was Stevie Wonder. You'd prefer someone could see, and you can't see underneath those gums. And so talk about your journey. How did you decide you wanted OraVu?
Well, I had been using the what people know of as the perioscope, which most people know that name, which is the dental endoscope that was made originally by Dental View, and now it's marketed by Zest. I'd been using that for about...
That was perioscope was made by OraVu and then sold to... Okay.
No. Perioscope was made by Dental View. Back in I don't know, 25 years ago. And so eventually, through a series of different things, it eventually ended up being owned by Zest, who now owns Perioscope, who owns the Perioscope company.
Sold to Zest, which owns Perioscope.
Yes. So I had been using a Perioscope for 10 years when I was working for Dr. Komarnitsky here in Phoenix. And we were approached by Michael Austin with the company that became OraVu, and they wanted to know what was working and what wasn't working for us with the perioscope. And so Dr. K and I conferred with them, and they conferred with others as well. But they decided that what they really wanted to do was get an endoscope, a periodontal micro endoscope, that was easier to use, easier to train on, more predictable in terms of the lifespan of the product, and easier to move around so that it could be used, say, for traveling hygienists who want to go to different offices and provide services, or whatever, whoever wants to train people. So they created this new DeVa endoscope, and I got to use the very first one that they had, which was their pre-production model. And it was really an awesome process of getting to give feedback on what was working with that one, and how much easier it was to use with the interface that they had, just a touch screen tablet versus a big, heavy unit. So now, eventually I became able to train others on using the DeVa endoscope, which I do both here at AZ Perio. I train other hygienists how to use the periodontal endoscope, and also speak and train other offices that purchase the scope. So I've just been kind of really excited to see the whole process evolve, how forward thinking this company is, because they took a product that was pretty good, but kind of a little bit stagnant, because they had, the company had gone through different hands, and the people who were really passionate about using the product really, really were devoted to keeping the technology. But it really took another visionary like Michael Austin to take it to the next step and create the new DeVa scope, which is direct viewing assistant. I think DeVa is what that's all about.
Is that what that stands for?
Yeah, direct
now,
viewing assistant.
Now, actually, when periodontist Korbinensky, when he came on the show, that was episode 898. That was a few years ago. He actually was talking about not ready. He came by my house December 2017, and he said it's not ready for prime time. But he was talking about this going on.
Right. Mm-hmm. And it's ready for prime time now, which is the awesome thing, because we have the OraVu company. I work for them as a master trainer. I'm not like on the board or anything, but we sell all around the world and train hygienists and dentists all around the world. So it's really, really taking off. People are starting to really get the benefit of it all over. It's they have a new system, which is called the DeVa Generation 2, or second gen, I guess it is, where instead of having this fragile fiber optic line, which if you kink it too much, it breaks, and then after 50 uses, you need to replace it. Well, now they have a line that has a tiny camera at the very tip of the fiber. So it's much more durable, and it has the ability to focus millimeter to infinity, so you don't have to bother focusing it. It's called just automatic. So they're definitely charging ahead their technology. It's really state of the art.
That is amazing, and I'm so dumb. The thing I'm excited about the most is I learned what the VU was. I just kept saying OraVu, and then you explained it's OraVu and Dental View. So what are your challenges of getting that out, and what is Michael Austin, and now he's a consultant to Ropar, which do you remember the founder of Ropar Pharmaceuticals?
Yes. So Michael used to be on.
But do you know the founder, periodontist?
Boy, no, his name is escaping me. Was it Perry?
Perry, there he is, and he was the coolest guy. He was the coolest guy. Perry Radcliffe, and now his son James L. Radcliffe runs that. But Perry, I couldn't believe it. It was in the '87, and I called him up, and I had this perio question. And he goes, you know what? He goes, that's a long answer, and I'm on my way to dinner, and it was at some fancy restaurant in Paradise Valley. He goes, and I was like 24 years old in 1987. He goes, if you come by, why don't I just buy you dinner? And I went there, and I think we drank from like 7 o'clock until they closed the restaurant down at 1. And I think he single-handedly doubled my perio knowledge. What a great guy, man. Just an incredible guy. But anyway, sorry to interrupt with that.
No, that's a great company. All the hygienists that I know love the closest product. So that's all.
So you know how he invented that?
No.
He will probably shoot me if I say this, but it's Dentistry Uncensored, and I'm pretty sure you and I are the only ones that are going to hear this show. He was sitting by a swimming pool right here in Phoenix, Arizona, where it's 110 degrees for half the year, and he started realizing, if I didn't put chlorine and acid in my swimming pool, it'd be a green swamp of mold and algae, just like the lakes in Kansas or whatever. And he started studying that. And obviously, if you put in chlorine, that kills. But when you every time you lower the pH by 1, it doubles the amount of hydrogen released. And next time you swish with closest, it's kind of tastes like swimming pool water.
This is true.
and then in endo, the guy for the apicoectomy retrofill material, whatever, it's a hard name to say, Saranabad or whatever it was, MTA. Same thing. He was sitting by a swimming pool, and they were repairing it, and the guy patched it, and he said, "So you patch that, and it'll work underwater?" And the guy said, yeah. So immediately the light bulbs went off on MTA. And the next thing you know, he had MTA, which costs more than any drug you could find. I mean, like a gram of it was over $100. And so swimming pools have been good to dentistry. Maybe dentists should swim more and get the third product. But so what's the challenges with getting hygienists to see what they're doing?
Well, they just don't have the access to the technology. I mean, I think all hygienists, we're all doing our best with the scaling and root planing that we do. And it's really disheartening when you realize that up to 40% of calculus can be missed on surfaces on the distals, on posterior teeth. So once you realize that, and that we can do better if we have this technology, it's really important to kind of move ahead with technology. Just as hygienists have embraced ultrasonic scaling because it's more efficient and more effective, I think more and more hygienists are going to be using the endoscope as it becomes more available. Availability to training, availability to the system. It is a challenge to learn to use it the first time. It probably takes about 10 cases to get it really under your belt, and then another 20 to really become completely proficient. But we're all about removing that calculus. That's kind of what we do as hygienists. We're really sad when we miss calculus, and if we can get something in our hands that'll help us to do better for our patients, that's really what we want to do. But dentists can use it too. I've trained dentists to use this equipment, and they're also kind of amazed that that this exists and that they didn't know about it. It's been around for, like I say, like 20 years now, maybe in terms of different kinds of equipment.
And we both live in the same town, and we've seen the big oral cancer company. I've been through this many times. I mean, just because something's logical doesn't mean it works. Like, I remember the oral cancer technology where they were taking basically OBGYN technology, and they were doing the toluidine blue smear looking for the deals, and they just took all that technology for women and applied it to the mouth. And you started looking at the number of people that die from oral cancer and this and that. But the first thing that happened is the insurance didn't pay for an oral cancer screening exam. And that means it's usually dead on arrival. I mean, when Röntgen came out with the X-ray machine, dentists played with it, but it wasn't until in the end of World War II when the longshoremen's unions started a dental insurance company, what would become Delta Dental, and they covered X-rays at 100%, and then like a domino effect all across America, all the dentists had X-ray machines the next day. And so I think the oral cancer screening is simply dead because there's not an insurance mechanism to pay for it. Do you agree with that, or?
Well, I think that we are definitely very insurance-based as consumers, and so maybe it can be difficult to get our patients to accept things that they have to pay for out of pocket. It doesn't mean that we should stop trying, because clearly insurance-led dentistry is not always the best for the patient. Just because the patient will pay for a PFM doesn't mean, an amalgam restoration, if that's all they pay for, that doesn't mean that that's all that the patient will agree to. So like working in a periodontal practice, we do have that conversation a lot with our patients. We'll have patients that only want to agree to, oh, my insurance only allows me 2 cleanings a year, so that's all I really want to do. And you have to have that conversation where, well, the insurance company doesn't really care about your periodontal disease. All they care about is what they've agreed to provide for you. So being a consumer, you have to understand that dental insurance is not the same thing as medical insurance. It's not going to cover everything that you need. So patient education is part of it. We do get patients to pay out of pocket for a lot of things that they wouldn't ordinarily do if they were just relying on their insurance. So patient education is a huge part of that. I think that if the patient sees a direct benefit from it, they'll do it. Like patients with fluoride varnish. We'll have many of our patients using fluoride and fluoride products because we know we can convince our patients the truth of the fact that they're having dry mouth and they're putting all their expensive restorations at risk if they don't get their caries under control. So I think that there is definitely a bandwagon effect. If insurance covers things will definitely, the floodgates are open and everyone jumps on that. But that doesn't mean that that the patients won't accept something that insurance doesn't provide.
But it's a cultural thing. It's a hard sell because when people just believe things luckily the only thing they all believe in is money. They'll always You can pay them in this money, and then they believe that it's a store of value, and they go use the money, even though all through history, it's just one currency collapse after another. I mean, my oldest sister's a nun. She really believes it. I couldn't give her a 4-hour presentation and make her Hindu. She'll always be a Catholic nun. In fact, you should see the picture my mom sent me yesterday. My mom made her a new outfits. My mom always sewed all 7 of her kids, all of their clothes and uniforms all through Catholic school, and she's still making the clothes for my 60-year-old nun sister. But if they believe that they should buy their house and car and take care of it, but they believe when it comes to health care, they should be a ward of the state, and the state takes care of them or their employer's insurance, it's a hard belief to change. I mean, it's not logical, but most beliefs are irrational. They just believe them. And gosh, that's hard. So do you, are you very successful about getting people to upsell people to pay out of pocket for things that aren't covered by their belief model insurance?
Yes. I would say we are, because people who come to the dental office already have a belief that they want to save their teeth. If they're not invested in their mouth, then they're not coming to the office. So you already have a belief system that you're working. The only thing is that now you have to kind of unpack what their perceptions are in terms of what they're able to pay for and what they're already expecting. I mean, it's kind of like you're saying, here in the United States, we have an expectation that you can smile and you'll have teeth. You can talk and you can be understood because you have teeth and a tongue and a healthy mouth and reasonable breath that's not going to scare off people around you. So all these kinds of things that are built into health are built into our societal expectations. So when a person comes into the office and they've invested many thousands of dollars in bridges and crowns and implants, and they're not flossing and they're not brushing, that's, to me, it's harder to get them to floss and brush than it is to get them to accept fluoride varnish. Sometimes I'll give them a choice between a couple of fluorides. I'll say, well, you can have the take-home fluoride that you have to use every night after you brush your teeth, or and it costs half of what it costs you if I put the varnish on now, and you can walk home and you can be done for 2 to 3 months. So convenience is a big part of it. You have to just talk to each person and know your patient and know what their own values are. Like I say, if they come to the dentist office, it's because they're trying to save their mouth, their teeth, their health, all these things that kind of play into that. So I don't really see that as being an issue. It's more.
And let me tell you how big convenience is. I just read a study 2 days ago where a school just made the Coke machines, they're in the cafeteria, but they kind of pushed them over towards the corner, and then towards where everybody's coming in and all that, they put big deals of ice, bottled water, and just by making the bad choice slightly more inconvenient and the water choice slightly more convenient, 20% of the students switched to water. And then when they would ask the student doesn't even know what's going on in their mind. They said, well, why did you pick water? And they go, oh, I love water. I'm thirsty. I love water.
It's right there.
And it's like, wow, 1 in 5 people that would have drank the soda. And I saw the same thing with milk. When they were like, why is Coke and Pepsi beating us up? Well, you can't go into 7-Eleven and buy milk that you can put in your cup holder in the 80s and the 90s. And when the milk farmers finally said, well, it's not convenient, it's the package, and they got a whole bunch of milk cells. So convenience is everything. Distance, it's one of the primary drivers of which dental office they pick. They always Google dentist near me. And the second one is they type in their insurance. So dentist that takes, Blue Cross and Blue Shield near me. So you know how they're thinking, but convenience is just huge. Does this on Dental Town, people are asking about OraVu, perio, endoscope. This guy has a really good question. He says, is this, would you think it would be even more helpful to add minocycline, Arestin? If you don't do minocycline or Arestin, do you consider it to be like that amount of value, or do you not ever use an adjunct antibiotic and you're just mechanically scaling, and do you think it's even better than Arestin or something?
Well, Arestin is really helpful in cases where there's active infection, separation, bleeding, but it's not going to be effective if you don't remove the calculus and the biofilm. If you can't expect Arestin to solve the problem if you haven't removed the root, the cause of the infection. So if we use, in my working with AZ Perio, we do use Arestin, but we don't use it as a first response after during scaling and root planing or laser. We use it more as to treat isolated areas. We find that you can, once you've removed the source of the infection, it should heal up on its own. If there are other factors that are preventing it from healing up on its own, then Arestin can come into play. Now, there are a lot of other kind of host modulation therapies that some offices use, like Periostat and things like that, and we do use those sometimes as well for people. But primarily, the basics are we use scaling and root planing, we use the YAG laser, we sometimes use both scaling and root planing with a periodontal endoscope and the YAG laser. And all those things are to give the root surfaces the cleanest possible outcome so that those areas can resolve. But as far as one of the problems, like talking about insurance, is if you want to use the minocycline in a lot of areas, it gets to be really, really expensive for the patient. So you not using it as a first line of treatment is probably better to do a larger overview of the mouth first with scaling and root planing or laser, that kind of thing. Definitely using the DeVa endoscope will help enhance any scaling and root planing. And I use it when called on to use in conjunction with our laser. Of course, the doctor uses a laser, and then we can kind of go from there and see how well the patient resolves. It takes about 9 months after the laser, so to really check anything. So we're not going to be placing anything under the gum line during that 9 months, but afterward we would check and see.
And what did you blow my mind telling me that DeVa stands for again?
Dental Visual Assistant.
My gosh, you never know when these acronyms actually mean something. Because when you said DeVa, I always think of, the divas of dentistry. I mean,
right, the hygienist diva, yeah.
I've met many people that told me they were a diva of dentistry, and they were always very fun to meet. And so that's what that meant, huh?
Yes.
DeVa Dental Vision Assistant. And is that how much is that?
Well, right now they are having special, and it is. I asked about that because I asked that question.
Because you knew I was going to ask.
I knew you were going to ask the money question, and I never pay attention to the money. Let me pull it up here real quick. Okay. The DeVa system retails at $28,200, and the current introductory offer is 40% off with $16,920.
Okay, tell me those numbers again. I'm slow.
$16,920 is the 40% off current offer that they're giving. The really great thing about that is they're throwing in the training, which is substantial. If you can get your training thrown in, you get someone like myself to come out and train your hygienist, on how to use the system and make sure that you're comfortable using it and understand how to use it, because that's what's going to make it possible for you to start paying off your investment. A lot of times, people they'll buy a really expensive piece of equipment and then it sits in the corner. So you really have to make sure that you're using this so that you get good at it. And then it just becomes your go-to instrument. And you're getting an extra, 320 each time that you use it, depending on your fee structures. And then that pays for your product, your device.
So I take it you only use this during root planing and curettage patients, and then the next big question they're going to say is, well, how much time do you block off for a procedure like that?
Yeah, you use it for any time that there's a periodontal issue, and it could be around an implant. You can look and see if there's any retained cement, or somebody's got a bunch of floss that's stuck down and around there. And you can use it with traditional scaling and root planing, only it's visual scaling and root planing. Usually your time is going to be more at the beginning when you're first learning. So maybe an extra half hour for each procedure that you would normally expect. And then it kind of pairs down to where you use about the same amount of time as you would for traditional scaling root planing after you know how to use it really well. So when you're first training, you might need an extra half hour or more for example, if you're doing say you do an hour per quadrant. If you're doing a full quadrant, heavy duty perio, you might even build in a full another 45 minutes to make sure that you're getting everything. The advantage of using a visual assistant like the DeVa, you can see whether you've missed anything or not. So you're not kind of guessing and going back over areas. You can see, and if you've already removed all the deposits, you just move on to the next area. You don't feel like you have to keep rechecking areas. So those areas can go a lot faster because you don't have to you're not second guessing yourself. So eventually you become to where you're doing about the same amount of time with the DeVa as you would with your traditional just instruments.
So DeVa's the one, just to be clear, that Orist was working on, right?
Yeah, he used to be the medical officer for the OraVu system, and then when he retired and moved, then they passed it on to Michael Rethman, who now.
You say when he retired, he moved?
Dr. Komarnitsky is now in Las Vegas.
Really? Oh, for
Yeah.
taxes, right? Was it just taxes?
No, I think it was because his wife, who's an attorney, her law practice was there. So once the kids were off at college, they moved she wouldn't have to commute.
I've lost patients my entire career that moved to Vegas just for the tax purposes, just to have no state income tax, and it's just a huge thing for a lot of people. I mean, Joe Rogan just moved his podcast from California to Texas just for that point. I mean, taxes are huge. So when you're in there, when you see a bleeding, so you're saying it's for 5 millimeter pockets and greater, or is that what you're saying?
Yes. And you kind of have to have something deep enough that you can actually insert the Explorer that shows you what you're looking at. If it's too shallow, you just can't see it. It's too narrow. Although you can, if you're trying, obviously, if it's above the gum line, you don't need it because you can see it with your own eyes.
And when you're down there under 5 millimeters, like let's say you're 6 millimeters and more, what percent of the time do you not see any calculus or anything, and it's just an exam saying, yeah, I'm good, I got it all?
I would say that's probably maybe 10% of the time.
So 90% of the time,
you find something that's been missed.
Yeah.
Yeah.
And I was blown away this year. We always, when I was in school, they told you to get the right answer that decay was caused by Streptococcus mutans. Now they know 4 millimeters deep into the cavity that there's no sign of Streptococcus mutans. But what really blew my mind a couple of years ago is that paper that came out. You got a whole nother, besides plant and animal, you got fungus, mushroom, that it was working with the fungi, and the fungi was making the protective barrier around it, and if the fungi wall it off, none of your antibiotics or anything's going to do anything. The biosphere is amazing, especially how they work together. I mean, how does a fungus and a eukaryocyte work together when neither of them even know they exist? I mean, it's just entropy is bizarre, isn't it?
It's pretty amazing. They do talk to one another. Who knows their little chemical signals, chemical signals. So I was going to say one of the really cool things about the endoscope is even if you have, let's say, one patient I had a distal like an 8 millimeter on the distal of 30. And we thought, oh, well, there's got to be some calculus down there. It's not a root canal treated tooth, so it's probably not a cracked root. But I got in there with the scope and, oh, sure enough, there was the root crack going all the way down. So sometimes you never know what you're going to find. And it was clean. There was cracked root.
So, a quarter of our listeners are still in school, and they do bizarre things with their iPhone. And when they first saw an intraoral camera, they're on Dental Town. First question is, how do I connect it up to my iPhone? So I already know what they're going to say. They're going to say, can this camera hook up to my iPhone, where they, take a picture, record a video? They love that kind of connectivity.
Well, yes, actually, it can, because the DeVa system uses a Surface Pro, which is the Microsoft product. So if your phone can connect to a Surface Pro, you can connect to your iPhone. I don't believe you can connect it directly and use it as a screen, but anything that you use, you can take photos, you can take video of what you're working on. So, for example, in that last
So what did you say? If your phone connects to Microsoft what?
Surface Pro, anything. If your phone can connect to a Microsoft Surface Pro, which is like a tablet,
Okay.
a touch screen tablet,
Yeah.
then you can connect your phone to that and use any images that you take using your DeVa. You can add them to your phone. So, for example, when I was scoping that case with the root fracture, immediately I just hit the button on the DeVa and it took a picture of it, and I sent it to the doctor and said, look, this is what's going on in this pocket. And Dr. Midnight said, sure enough, oh, there's that root fracture. We'll have to have that one out. So it's definitely great because you can use it almost like a subgingival intraoral camera. And you can save those images. You can save video from what you're using, from what you're doing, and show the patients what you found in the pocket, and show providers, oh, this is what's going on in this pocket. That's why we're going to see if it heals before you put that expensive crown on that tooth. There's a lot of options that are opened up once you're able to see under the gum line, and document what you've seen very easily using that Surface Pro.
Yeah. Now, are you doing that? I mean, is that what you do? You take pictures home to your husband at night of subgingival calculus on your iPhone and as the appetizer?
That would kind of be against HIPAA, but but I definitely like to show it to the patients and to my colleagues at work.
Yeah. Well, you walked into another subject that we need to go to, and that is you were talking about how the special today, and by the way, this isn't a commercial. I don't do commercials. She didn't pay to. Did you pay me money to come on the show?
No, sadly, I didn't know there was an option.
Well, then you tell Horace then that he owes me a beer, and I know he'll pay up on that. But you were talking about this DeVa Endoscope is $16,900, right?
Right.
And there's another thing. You mentioned the word laser. There's a LANAP, and that's what is that, about $135,000? And so the question is,
I think so, yeah.
Are you and Ralph, and I always say Ralph because I've known him from 5,000 posts on Dental Town, but is Ralph using the LANAP?
I believe that all the periodontists at AZ Perio use the LANAP. So yes, the LANAP really works very well for majority of patients. We just have to, we can use it in conjunction with the DeVa as well in the offices that we have the DeVa. But LANAP is a very, very valuable procedure for patients. Sometimes we don't need it for all patients, but it's a little bit easier to get predictable results on back teeth, I think, with the LANAP, but studies need to be done more to kind of nail down those figures so we can actually have a conversation, say, look, this is actually, instead of just saying anecdotally, these patients did great,
And where I was really pleased with the LANAP is which is owned by Robert Gregg and Don Gregg and Millennium. They were on episode 973. But my favorite LANAP was done 4 years ago with our local periodontist, Alan Honigman. Do you know Alan?
I don't.
And he came out first, and whenever you're first and you climb up the pole first, everybody's just going to shoot an arrow and throw a rock at you. And that guy was just eaten alive for him endorsing this LANAP. And of course, most species eat their own children. They don't eat other species' children. And my gosh, the abuse he took, and then one by one, people just come on and say, nope. Alan was right. Alan was right. Alan was right. And I always tease him. I said, did that bother you? All the abuse you took by, and he said, no, because all the bald dentists in dentistry are just bulletproof. And he has a gorgeous bald head. So Alan Honigman was right on Dentistry Uncensored in May of 2016. You say, I'm calling it LANAP because Ralph, let me give you a little background on Ralph. So on Dental Town, when someone would ask some question where it'd be like you'd have to find a minister who could quote the Bible or something, you know what I mean? And I would always, whenever I was stumped, I would email just two people, Trish O'Hare, the hygienist here, who had peri reports, and Ralph. And it was because I knew if I said it to them both, that one of them would answer it within 4 or 5 seconds. But Ralph, his comprehension of the literature, and of course, that's all Trish does is read the literature. But my gosh, Ralph is just incredibly, that guy would do nothing if he couldn't sort, quote, 50 PDFs on it. So the fact that Ralph is into this LANAP and using the OraVu is all I would need to know. Yeah. And that's not a commercial from either of them. That's just, you'd have to know Ralph. He's an intense guy. He's a black belt. You posted on Dental Town. You say, I work in 2 offices, blah, 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 blah. But anyway, it says, where I frequently recommend water pick for those who refuse to floss. But the other office, they don't like the water pick because they fear the patients might damage the gingival attachment to an implant. So do you think things we do for our teeth, brushing, flossing, water picks, are kind of different for natural teeth versus implants? And what are your thoughts on water pick today?
Well, obviously, I think that any patient who's able to do their brushing and flossing alone are not going to be getting deep enough to damage an implant without really trying hard to hurt themselves. So not that they couldn't if they really tried hard enough, but I actually really, really like water picks. I promote them to most of my patients that have implants. They have really, really good science behind the new water picks. I tend to encourage people to use the lowest settings around their implants, just because I don't want them to be shooting water up and around too deeply and too aggressively around their implants. But like I say, I think that people have to try pretty hard. Most of the time, people don't try hard enough to get underneath the gum line with their brushing and flossing. And professionals, we know how to be careful and not over instrument around implants and things. There's definitely going to be that one patient that overdoes things, but that's the far end of the bell curve. Go ahead.
Do you remember the shower floss?
Oh, yeah.
Yeah, and it came with 4 utensils, and
Mm-hmm.
it was really great. But I shouldn't say this on Dentistry Uncensored, but nothing's ever stopped me before. But I was getting ready to go in the shower, and I had 4 boys. I think they're like 1, 3, 5, and 6. And when I got in the shower, if you knew what one of the boys was doing with that water pick, I thought, okay, so this is not working. But what I thought was so mind-boggling about the water pick is the reality is if you tell a kid in braces, or you tell the husband, or you tell someone to you start using a water pick, it's on the it's on the mirror, it's on the counter, it makes a mess. And whoever is cleaning the house does not like it at all. And so I was really excited when the water pick came out with the shower flosser, so you could take the water pick in the shower. I do everything in the shower. I shave, brush my teeth, floss, go to the bathroom, everything right there.
Right.
And well, it's the same pipe. If you follow down the shower drain and the toilet drain, the plumber can give everyone a diagram, but those pipes actually meet right up. And so I thought the water pick or the shower floss was perfect, but not if you share your shower with someone who's
Right.
2 years old. But I think the taking it in the shower. Do you use the shower floss in the shower, or do you use it at the bathroom sink and get it all over your mirror, and then your husband cleans it up?
I use the countertop model, and he uses his own countertop model, and he doesn't make a mess. But it's a matter of practice. I know we both use the countertop model. We each have our own, and I do know a lot of patients that don't like the mess, and so they get the handheld battery-powered one, which they can use either over the sink or in the shower. And if they don't want to have one on their shower, actually attached to their shower. So, there's a lot of different options out there for me. I usually tell my patients, go online and Google how to use it, and it'll be a lot less messy for you the first time, and just get out a really big towel, because expect to make a mess and have a towel ready. But, really, it is messy, but it works really well. And
the one thing, Trish, I have to credit Trish for so many periodontal concepts that she took the old wrong ones out of my head and put new ones in. But her concept of dry brushing, that, when you're talking about brushing, you don't need toothpaste, you don't need sodium lauryl sulfate, you need to mechanically brush with a soft bristle, and the bristles need to be straight for 2 full minutes. And I don't think anybody brushes for 2 minutes. And so I think the only options are, if you're one of those people who get in the shower in the morning and want to wake up, the first 2 minutes you just stand under the water, and you got 2 minutes. Or what I tell all my patients is, when you start brushing, that's the perfect time. You got one hand free. Go lay out your clothes. Go do this. Go turn on the coffee pot. Do something, but do a routine and keep measuring it until well, if I go lay out my socks and underwear and shoes and dental uniform and turn on the coffee pot, if I go do these 4 things, I got my 2 minutes in. But it's just, time is it's everything. And that's the longest 2 minutes of the day, is when you're brushing your tooth. And there's something, and have more sympathy for gaggers, because there's 7 kids in my famiily, and me and my sister Kayleen, it's both an issue. Gagging by brushing, and the only thing that really helps me to do it is that red close-up toothpaste. For some reason, it just doesn't gag. But your standard Crest and Colgates and all the stuff like that. But you trying to get the patient to change their behavior blew my mind when I saw that one study where identical twins needed a quadruple bypass, a coronary artery bypass graft, and one got it because he had the insurance or whatever. It's about $100,000 procedure, and the other one didn't get it for whatever reason, usually finance or whatever. And then they come back, and you look at the life expectancy. The one who changed the behavior, quit drinking, smoking, and started exercising and got healthy lifestyle, but didn't get the bypass, lived 3.5 years longer than the person who got the $100,000 surgery but didn't change any of their behavior. And at the time in my life when I read that, I had already seen it with replaying curettage, where some people, you tell them to do 4 quadrants and they don't have the money, don't have the insurance, don't get it done, but they change. And then the other ones get it done, and they wouldn't change. And I always said from day one, I'd rather take the one who didn't get the 4 quadrants of surgery that changed their daily behavior than the one that, you go in there like Superman. You think you're going to do all this stuff and make the day, but you have to change their behavior.
Yeah, you can't. They have to change it themselves. You can open that door, but if they don't change it themselves, you're fighting a losing battle. You can do the best you can for them, but if they're not going to do their work at home, until they get that light bulb that goes off in their heads, they're not going to be motivated to do it themselves. And that is definitely, I think that's definitely true. Some people will pay the dental office to do everything that they won't do for themselves. And that's not going to be a recipe for health for themselves. They have to do what they can. And of course, ideally both. Imagine the patient who got the bypass and changed the behavior. They're going to live the longest of all and have the healthiest and most rewarding life with that they can.
I always think dentists are the most funny because the older ones my age, it's a conservative bunch of old men, and they didn't want to hear anything about holistic. They didn't want to hear anything about alternative. They just the surgery, the pharmaceutical, and then you watch them get their first disease. And I got one right now who's just really got hit hard with rheumatism. And it's funny how the first thing, that one doctor told him to put him on methyltrexate. He's like, oh my God, that's like chemotherapy. And another one said, so what's he doing now? Changing all of his diet, changing his exercise, going to a dietitian, going to a naturopath. And it's funny how when it's you, it really changes. And so when if I bought this from you right now, is that something like I would pick it up and use it right away? Or is it something like an iPhone where I remember when I got my first one, it took me 40 days and 40 nights just to learn how to use it. What's the learning curve on this?
Well, the learning curve is that, like I say, it takes, you have to start learning your equipment. Kind of like when you first started, hygienists and dentists, when you first go to school, you have to learn what the instruments are. You have to learn how to do viewing with the mirror. And that's a big challenge the first time you do it. So if you adapted to that very quickly, you're going to have a shorter learning curve when you start to use the DeVa. If you do, it does help if you have training, to have training and to watch videos and see how other people do it, and to do things that challenge your mind to learn, to look at, when you look at something on the screen. It's kind of like learning to use a mouse. Now everyone knows how to use a mouse, right, for their computer. It's very much like that. You're not looking at the mouse when you're using it. You're looking at the screen when you're using it. So it's like the mouse times 10. So maybe you get a couple days of training with a couple patients, and then you have, after you've practice on a typodont, practice using, tracing patterns on a page and you can follow the patterns when you're looking at the screen and not looking at your hand, and then practicing on the typodont, and then finally having an actual patient and doing a couple of patients. And then after the trainer leaves, you get some patients by yourself, and they're isolated areas. So I'd say a good 10 cases in, you're pretty good to go. But that doesn't all have to be with a trainer. And the more patients that you have, the faster you're going to learn. If your patients are spaced out, it's going to be a lot slower process for you. So, and once you're 20 patients in, you're pretty good. You're pretty good to go.
20 patients in. And how are you, how does someone get trained? Do you have it, anything online? Like you're here in Phoenix. What if they're in Beeville, Texas, where 4/6 of all my grandchildren live?
We can do distance learning, but you really have to have an in-person trainer go to them. So we fly trainers out, and we help them know how to set up the equipment and how to use the equipment safely and keep it in good repair, and then make sure that they have time set aside with patients so that we can practice with real patients, have them start training on real patients. And then, of course, we have support. So if they have questions, they can email me or email the other trainers and ask their questions.
So, a dentist on Dental Town asks, he says, I have a question. As doctors, why are we calling an SRP a deep cleaning when it's truly more involved than that? Sure, it's easier to get the patient to nod their head when you ask them if you make sense to them during the treatment presentation, but I don't think the patients really understand the value or purpose behind the SRP or what it can do for them by calling it a deep cleaning. Patients want their dental care delivered in simple terms, but aren't we devaluing by saying deep cleaning? I've had patients say to me, well, why can't you just clean deeper when you do the normal cleaning? Are there any other phrases that you use for scaling and root planing, and what do you call it?
Well, like you say, patients understand scaling and they understand deep cleaning. So you kind of have to know where your patient is coming from. So if you have a patient that you can explain what scaling and root planing is and how you're doing a root debridement and why you can't do that as part of their quote unquote normal cleaning, there's good words to use would be root debridement. Other kind of things would be definitive scaling, periodontal debridement. If you can kind of introduce those kinds of words, then the patients might start to appreciate more that you're doing more than just a quote unquote cleaning, because cleaning itself is kind of like a house cleaner or all these kinds of things. We don't really get a very good image of what someone who just cleans does. But if we're performing debridement and other words I'm trying to think would be antisepsis or there's words, I mean, it's kind of off the top of my head, but I know that full mouth disinfection is also a word that sometimes people use. I like disinfection versus sterilization because obviously we're not really sterilizing the roots, we're disinfecting the roots. So full mouth debridement, full mouth disinfection, root debridement, all those kinds of things do help to kind of make it sound more like we're actually doing something that takes great skill and is in the patient's best interest. It can be difficult to get patients to understand terminology, dental terminology. So we tend to dumb it down a little too much. And I agree that that doesn't do us all any favor. Does it help the patient to understand the importance of what they're asking, of what we're asking them to do?
I noticed the periodontists are acting very endodontously, where the endodontists don't like the term root canal, and they're trying to get everyone to say endodontic therapy. And of course, the periodontists took 3 seconds to log on and say it should be called periodontal therapy, not a deep cleaning or scaling root planing. Do you like the term periodontal therapy, periodontal treatment, or do you think that's more Greek and Latin, or where do you come in on this?
Periodontal therapy, I believe, could. I mean, I don't know the exact. If you were to go in a glossary and find out how they break these things down in the periodontist glossary, but I worked at a previous periodontal office. We always called it supportive periodontal therapy versus periodontal maintenance. We just called it supportive periodontal therapy, and periodontal therapy is definitely a good way to consider scaling root planing, because we don't really do root planing anymore. Root planing was, whoa, you have to have those smooth, glassy roots. You have to make sure that they, you all the cementum off the roots, which of course we don't try to do that anymore. So scaling and root planing is kind of an insurance carryover, I think, that the codes have been written for, quote, scaling and root planing. So that's what we call it, even though what we're doing is more debridement and periodontal therapy, periodontal debridement. I do like the term periodontal therapy, but for insurance purposes, if the patient gets their bill and they see they've been charged for scaling and root planing, then we kind of have to have told them that what we're going to do is scaling and root planing.
So I want to, this is Dentistry Uncensored, so let's piss some people off and ask questions that gets everyone mad. Hygienists are talking more and more about direct access, and I'm a big fan that a hygienist, she's an American, she has rights, she should be able to open up her own business. It's very embarrassing when my colleagues give money to political action committees at the American Dental Association where they hire lawyers and pass laws that says, no, you can only work for me. I mean, it's economic violence. You went to school, you have a 4-year degree, and quite frankly, when I would go on places, like resorts and stuff, and they'd have, you could get a facial and you could get your hair done and you could get all the stuff like that, and I just wanted my teeth clean. And they said, a lot of people ask for that, but we can't do that because it's against the law. Why are my American colleagues hiring lawyers to make it illegal for you to do what you did, learn from 4 years of college? I so wish that the hygienists could get some big law passed and all the dentists would have to work for the hygienist just for like 50 years so they can kind of remember that lesson. But it's economic violence. Why is it an issue?
It's very definitely a protectionist kind of approach. There's a feeling that if the hygienists are able to access the patients directly, that somehow the patients won't want to get care from the dentist. I personally don't believe that. I believe that while I personally would not want to be my own business owner, I would love to have the option if I wanted to maybe work part-time in office and have a DeVa and run out and do therapy at a bunch of different offices and run my own business. I think that I should be able to do that without having to be paid through a dentist. I don't see that there's a conflict. I think we can work together, and we're better and stronger if we all work together as a team instead of fighting one another over who gets to be the boss. I know a hygienist who owns a mobile dentistry company.
Kara?
And
is it Kara?
Sorry?
Is
No.
her name Kara? Is it here
not.
in town or is it here in...
It's actually Mobile Dentistry of Arizona. And she has to be paid through, she hires dentists, and she can't be paid, she has to be paid through their licensure or whatever, which is insane. But there you go. And so to me, that's really silly. If you can own a practice, but you can't be paid to actually be the provider. As soon as insurance provides direct reimbursement, I think that's going to go away. And it should
say
away.
That again. When what?
Once we go back to the whole insurance thing. Once insurance starts reimbursing dental hygienists and whoever as direct providers, then it will solve that conflict. But I think that there are states where hygienists can do direct provision, and
that's why it's necessary. Number one, I'm always suspect that when someone has a idea that's so great that they have to kill you to convince you of it, or go get a law that if you break, they have the right to kidnap you and put you in a cage. So it's all starts with violence. And when Colorado did this, I'm only aware of about 7 independent practice hygienists. They were all in very small towns. Of course, they didn't have the lucrative money after a cleaning exam or x-rays or whatever to go have their own place. So they just took out, you go in their house, and what used to be a dining room table is now they got an operatory and people come by and she cleans her teeth. And if she sees something, she writes up a referral and they drive 25 miles up to town and you go talk to that dentist and he's in love with her. I mean, he just thinks it's fantastic. And with humans, distance is everything. And, if it's not available, accessible, on every corner of America, you can buy liquid sugar, liquid nicotine, liquid caffeine. I mean, they sell caffeine, nicotine, and and sugar on every corner. And then the dentist, their best idea is to limit the access of getting your teeth cleaned and do it with economic violence through a law. It's just so that poll on Dental Town, it's so 22%. Do you support hygienists opening up their own clinics? 22% said yes, and 62% said no, and 16% said no opinion, I don't know, and that's really, really cool. Maybe they're really young, maybe they hadn't thought about it, but I mean, that's 1,000 people voting, and I just cannot believe. It's just kind of sad that 2 in 3 Americans think that, look at religious converts, change to my religion or I'll kill you. I mean, that doesn't work. My idea is so great, I had to get laws passed individually in all 50 states just to implement my great idea. And then, and the same thing with dental therapists. Every dental therapist, the people building the schools think, well, if we create a dental therapist, when she graduates with $1 million in debt, she's going to cut down a tree and carve out a canoe and canoe up the river to where a bunch of native people live and do free dentistry while living under a tree. And of course, they graduate just like everybody else and want to go to the richest part of Scottsdale and get the nicest apartment and a Beamer and all that kind of stuff. So that with that being said, every dentist I know that has them, they love it because you go in their office in the first 2 rooms, they got 2 hygienists. The dentists don't want to do the cleanings. They got 2 people to do that. And then with these dental therapists, all restorative, they numb up and they put on the rubber dam, they do the prep, they do the whole filling, and he doesn't want to do that. And then he's just sitting there at the end and he can just do root canals or crowns or emergency patients or whatever. And I'll tell you what, you go to any dentist who's had their own hygienist for 10 years, it's hard to take the hygienist away and get them back in that mode. And I don't know any dentist that has a dental therapist that would ever, because I got to tell you, 33 years in this, I graduated in 87. My worst hour is when you look at the chart and there it says, patient, MOD composite on 2, 3, 4, and 5, and you just got to sit down for an hour, no shortcuts, and knock this thing out. And if you told me that, Arizona, Laura Corbin's now can come in your office and do all that, well, I would never do another one. They're fun at first. You take all these courses around, you go see the Bertolottis and everybody. But man, after 10,000 MOD composites, really, do you sit there and think about it the night before about how excited you are to go do 4 MOD composites in 1 hour? I lost love. The only thing fun with it is the different patient. It's not the same technique. So what is your official stance on independent practice and dental therapy?
I'm all for it. I think that we need to expand opportunities. I think that dentistry in general needs to be part of the medical field. So we need to be able to have hygienists going into hospitals and providing therapy to like intubated patients to keep them from getting respiration pneumonia. And we need to be able to have dentistry, like you say, much more convenient. We need to be able to have the dentist office in the Walmarts, have them all over the place. Have the, I think airports are a great place to have dental offices. People on layovers can get their dental care. I really think that expanding access is going to help improve people's access to care. It's really difficult for people to get care in rural areas. Because people don't want to practice in rural areas. They can't afford to practice if they have great student debt. So anytime that we can improve access to care, we're going to improve things for health, and we're also going to make it better for people to have more opportunities to practice. So I'm all for it. I'm all for expanding practices for.
And plus, when they don't, when it's not done, and dentists just sit around in Kansas and saying, well, they couldn't afford to do it. They could. We'll never know, doc, because you went and hired a thug lawyer to write your law for the mob. Just let them do it, and then when you see how it naturally takes place. I mean, I'm a libertarian. I've been a registered libertarian forever. I mean, I know we're never supposed to talk about religion, sex, politics, violence, but I don't believe in any. I think it's a binary star system that's taken us down a road of from Abraham Lincoln to today. I mean, there's 150 years of just one drove the car, one robbed the bank. It's just a binary star of corruption that's led to these deficits and all the crazy things. So I'm a libertarian, and I think the best way to find out if this works is leave you alone. Yeah, leave you alone. And if every hygienist goes and drops dental insurance and goes to the nicest place in Scottsdale and charges what's the most money you've ever paid to get the bouffant thing in your hair?
Oh boy, I am a really, really bad person to ask that, because you can see I have really long hair. I don't get my hair cut very often.
Holy moly. Hold that up again. That's like
it's
how
really,
long is that?
Really long.
Is that 2 feet, 3 feet? How long is that?
It's probably maybe 2.5 feet. Maybe
how
3.
many wigs for bald dentists could you make with that hair? How many bald dentists do you
10,
think?
I don't know, depending on how long they wanted them.
So you have you're providing a hands-on DeVa Endoscope course on November 6th. Is that what I hear right?
Yeah, that's correct. We're for the people who are local or down at the Sky Song building at Scottsdale Road in McDowell. We're having a 12-person.
At the Sky Song building?
Yeah, the Sky Song building.
Is that 2 words or one?
I think it's one word, Sky Song.
At the Sky Song building in Scottsdale. Yeah.
And if you go on the OraVu website where they have their education under company, I think they have education, oravu.us./education. They have the flyer for it. For people if they want to sign up. But yeah, we're having limited space so that we can do it very safely, and everyone in masks, everyone getting their temperature taken, so we can minimize any possible risk of, everyone should be healthy when they come in. But, if anyone doesn't know they're not healthy, we'll all be wearing masks and gloves. But at any rate, they can come and they can get their hands on an actual endoscope and practice it using the Typodont and ask me any questions that they might have. I'm sure that people will have questions that they aren't able to ask today, and see what it's like to use it. We'll even throw in a little bit of food for them. So,
now you just got me.
Yeah, you should come.
I've never said no to a sandwich. So I just found it. So if you go to OraVu, and so think oral view, VIEW, but it's OraVu, VU. So Ora, ORAVU.us /events. And then it says removing the blindfold, non-surgical periodontal therapy using the dental endoscope, November 6th at 8 a.m. at 1475 North Scottsdale Road, 2nd floor. Let's try something new in this new, crazy, upside-down, mix-up world. We decided to try something new. We are hosting 3 separate seminar sessions and allowing only 12 attendees per session. We also will provide mass protective shields, hand sanitizers, and temperature checks will be taken with unlimited Jameson whiskey on ice. Interesting. I like that.
Dr. Ferran is bringing the Jameson. So
that is that's awesome. So how are you going to get the word out for that?
Well, we are promoting it on social media and through our hygiene circles also, and from you just now. You just told everyone. There's no better forum. So thank you.
I'm going to help my homie here. Removing, I love that, removing the blindfold. I think you should have a subtitle, removing the blindfold, subtitle, how Stevie Wonder learned how to be a hygienist.
you know, he could probably do it without having to worry, because he was that awesome. So
Wasn't he though? Wasn't he?
yeah.
Okay, so yeah. Well, I'm going to try to make it. So now, do you think because of COVID, and so I know you've gotten past an hour, and I need to shut up and get off, let you go. But how are you doing through COVID? What major changes did Ralph have to make in your office or the office that you work at? I know Ralph has 7. He's the managing partner, periodontist, of 7 offices, and I know you work at the downtown one, and he's out there in Scottsdale where all the rich people live. But what did you have to change? You know, what do you have to change? Because what I'm really curious about is, what I wonder is all the stuff that we're doing now, will we be doing 10 years from now, or how much of this is just hype through the pandemic? Because I've lived this through HIV. A lot of the HIV stuff, you know, I remember telling the dentists back in Kansas they had to wear gloves in the 80s. I mean, they were mad, and they had shotguns. They didn't want to wear masks. They didn't want to get rid of cuspidors. They didn't want to have water coming from the street all the way to their handpiece. And so they did a lot of things that lasted. What did you guys do that you think we'll still be doing 10, 20 years later when the next pandemic gets here?
Well, I think that you make a really good point that the changes that came in after HIV came to stay. And so I think most of the changes are also here to stay. I think that with greater use of HVE, high volume evacuation devices, we're able to continue to use things like our Cavitron units and our air polishers. Those are things that a lot of offices have gone away from, but we are using them because we have really good high vacuum evaluation systems. So we've changed some of those up. I think that we will not go back from that. As a hygienist, I've gotten really used to liking using those. Wearing face shields, I wouldn't go back. No, you couldn't. You would have to pry it from my hands.
You're dead cold hands. You're dead cold hands.
Yes, and the way that that barrier wrapping our operatories is much more like they teach in the schools. So the way the schools practiced, and then you got out of school and nobody did it that way. Well, we're all doing it like the schools did. So
Which is what do you call it? Barrier practice?
Barrier wrapping our operatories.
Okay,
so
explain
lots
what
of
barrier.
plastic.
Explain what barrier wrapping your operatory.
Okay, barrier wrapping. You clean your operatory, and then you cover everything with plastic that can be covered with plastic. So it takes a little bit longer to set up and to tear down, but you're minimizing the overall bacterial load and viral load that's getting left on surfaces because those barriers get thrown away. And also, of course, we're wearing disposable gowns with each patient. There are all these things that we're doing that.
And what do you think that's about, wearing a disposable gown? I mean, that was still the main HIV thing. They made our office change in '87 that really hacked off staff, because here we are in Phoenix. It's 110 every day for 6 months of the summer, and our office uniform was white shorts, a T-shirt, said "Today's Dental," and white tennis shoes, and the staff just love coming to work in a T-shirt and shorts. And because of AIDS, they couldn't wear shorts; they had to wear long pants and long sleeves. And I'm trying to explain. My assistants are asking me, well, how am I going to catch AIDS by wearing shorts? And I'm like, I have no idea. But our overlords.
Yeah. I think that the HIV, it kind of just pointed up the fact that other things that people were getting exposed to were going to be protected from as well. But wearing a disposable gown basically means that anything that the patient coughs up on you doesn't get transferred to you or the next patient, because you take that off after the patient's gone, and then you don't have anything. It's a precaution for sure. It just makes it that much easier to not worry about somebody sneezing at you.
I know you're a girl, and girls don't tell their age, but so it's hard to tell what you think. But it seems like in Arizona there's 2 groups of people. There's 55 to 70-year-olds like me that are taking this thing serious and kind of avoiding coming into the dentistry. But it seems like everyone in Arizona under 40 just thinks this is crazy. I mean, so do you personally, worry about catching coronavirus? Because there were a lot of hygienists all over the news that were scared and crying and upset. But I want to talk about you, Laura. Are you afraid of catching this, and are you fearful of this?
I think that we have to take it very seriously. I think that working in a healthcare environment, we have to make sure that we are doing everything that we can to minimize our exposure. But I do feel like working in the healthcare system, we're exposed to a lot of things. So to me, I'm no more afraid of catching coronavirus at work than I am afraid of catching other communicable diseases from my patients and coworkers. So I think this is a good thing that we're kind of tightening up our protocols and having everyone wear masks and things, because we're spreading less things around in general. I am not a fearful hygienist in the sense that I worry like every day that I'm going to catch something from my patients, because I feel like because of the precautions that I'm taking, I'm not going to catch them. I'm minimizing the likelihood that I'm going to catch those things. So I believe in the disease theory that if you can minimize your exposure and you stay as healthy as you can, generally, you're not going to come down sick for the most part. So, but do I understand why hygienists were afraid and not wanting to go back to work and things? I totally understand that, because I have subbed in offices that I would not have wanted to go back to. They were not going to provide their staff with the kind of protections that they need. So just because I happen to be very fortunate and I work in offices that are on the forefront of really good care for their staff and for their patients, doesn't mean that everyone's in that same boat. So for me, I'm not afraid. I feel like I can do my job and stay healthy. If I do get sick, it's probably, hopefully I won't I won't be very sick, because I do a lot to try to stay healthy. But we kind of just we do our best and keep working.
And do you worry? And I know I'm running over, but are you worried that we had to close down between St. Patrick's Day and Cinco de Mayo, and do you worry? Does Ralph worry? I mean, with 7 offices, do you think there's going to be a fall outbreak that maybe we'll have to close down again, or do you think that since we all adjusted with the PPE and the temperature and the barrier wrap and everything that we've done, that we're like hospitals will be essential, will stay open, and they'll close more like bars and gyms and restaurants? Or do you think it might be us again?
I think that this is just speaking for myself, not speaking for the company, because I can't speak for the company. But I would find it really unlikely that dental offices would be required to close unless some event happened that you suddenly found out that a whole bunch of people were getting sick after having visited dental offices. And that hasn't happened. To my knowledge, there hasn't been any chain of, oh, everyone's getting sick because they're going to the dentist. I don't believe that has happened. And I don't think that it will happen. So the likelihood that it will is to me really, really low. I think people are more likely to get sick if they do, crazy bar activities where they get all jammed in together and go to concerts and nobody's paying attention to social distancing. I mean, we can be smart about this. We can protect ourselves. We don't have to do those things. And we can, if we are smart about it, then we can reopen most of our businesses without feeling like we're going to put ourselves at risk, or our customers and our patients and things. I mean, why would we want to put them at risk? So be smart about it.
Well, you're confusing me because you're asking Americans to be smart about something, and that's a tall order there, Laura. You must be very optimistic. Laura Corbin, RDH, AAS, BFA, removing the blindfold master trainer at OraVu. November 6th, right here in Scottsdale. And anything I can do to help the cause, let me know. Thank you so much for coming on the show. It was an honor to podcast you, and I hope to see you there. I'm going to try to make one of those.
Yeah, please do.
November 6th, and Laura will probably bring like Listerine, but I'll have the vodka or Jameson. I'll have the real stuff.
Okay. Thank you so much, Howard. I really appreciated talking to you, and it was a treat.
All right. Have a great day, Laura.
Thanks.
Bye-bye.